All right, let's dive into a topic that is absolutely essential if you're managing patients on the wards: colonic diverticular bleeding. Seriously, this is the #1 cause of acute lower GI bleeds, so knowing your way around it is pretty much non-negotiable.
So let's just start right there with the most fundamental question. You get that page, right? A patient with a huge amount of bright red blood. What's got to be at the very top of your list? Well, you guessed it. It's what this whole explainer is about: colonic diverticular bleeding.
Okay, but here's where it gets really interesting from a clinical standpoint. Somewhere between 50 and 90% of these bleeds, they actually come from the right side of the colon. Just lock that fact away for a second because it sets up this really fascinating paradox.
And here is that paradox. In Western countries, most of those little pouches in the colon wall, the diverticula, are actually on the left side. So what's the deal? Why is the bleeding happening on the right if all the action seems to be on the left? Don't worry, we are going to get to the bottom of that.
So to really unpack all this, we're going to follow a simple clinician's pathway. We'll start with who gets it, then the anatomy of the bleed itself, how to spot it, how to diagnose it, how to stop it, and finally, the chances it'll come back. First up, Section 1, a common culprit. Let's get a handle on the numbers and figure out who is most at risk for this.
You know, having diverticulosis is super common, but bleeding from it, well, that's pretty rare at first. But just look at how that risk builds up over time. By the 10-year mark, we're talking nearly 10% of patients with diverticulosis will have had a bleed. That's a really significant long-term risk to keep on your radar.
And these are the big ones to watch out for. When you're looking at a patient's history, things like being over 70, having diverticula on both sides of the colon, obesity, and especially taking aspirin or other NSAIDs, those should be major red flags pointing you towards a diverticular bleed.
Okay, moving on to Section 2, the anatomy of a bleed. Now that we know who's at risk, let's get into the nitty-gritty, the why and how this actually happens. So the whole story really starts with this one structure, the vasa recta. These are tiny little arteries that poke through the colon wall. When a diverticulum forms, one of these arteries gets stretched right over the top of it, kind of like a wire stretched over a balloon. And there's only a super thin layer of mucosa separating it from everything passing through the bowel.
So you can see the sequence of events here. That exposed vessel just gets beat up over time by passing stool. This causes weak spots in the artery wall, and eventually, boom, it ruptures. And this, right here, answers our paradox. The diverticula on the right side tend to have wider domes, which means those little arteries are stretched over a bigger surface area, making them way more likely to get injured. And that is why the right colon is ground zero for most of these bleeds.
Section 3, recognizing the signs. All right, so what does this patient actually look like when they show up in your ER or on your service?
This is the classic picture, and if there's one word you remember, make it painless. Unlike something like colitis, which usually hurts, diverticular bleeding is typically just a sudden, shocking amount of red or maroon blood. Maybe the patient feels a little bloated or like they have to go to the bathroom, but major pain should make you think of something else entirely. Oh, and if you see clots in the stool, that's a huge clue pointing you towards a colonic source. On to Section 4, the diagnostic pathway. You've seen the signs, now it's time to make the call. How do you actually confirm it, and more importantly, find out exactly where it's coming from?
And it all boils down to this one single question. Is your patient hemodynamically stable, or are they unstable? Is their blood pressure tanking? Is their heart rate flying? Your answer to that question is going to dictate your entire diagnostic game plan.
Yeah, choosing the right tool for the job here is absolutely critical. For your stable patient, a colonoscopy is the way to go because you can find the bleed and fix it at the same time. But for an unstable patient who's actively bleeding a lot, you just don't have time for a bowel prep. That's when you reach for a CT angiography, which can find an active bleed in a hurry.
Section 5, stopping the bleed. You've nailed the diagnosis. Now for the most important part, how we're going to put a stop to it.
So if you're doing that colonoscopy and you find the culprit, these are the main tools in your toolbox. You can use little clips to literally pinch the vessel shut, you can use a band to tie off the whole diverticulum, or you can use thermal probes to basically cauterize the site.
And it turns out the technique you choose really matters. A big meta-analysis found that using a band was way better at preventing an early rebleed compared to clipping. We're talking 8% versus 19%. That is a huge difference in patient outcomes.
So, what about surgery? The thinking on this these days is crystal clear. It is an absolute last resort.
Less than 1% of patients will ever need it. It's really only for those rare cases where all the endoscopic and angiographic tricks have failed and the patient is still unstable. And finally, Section 6, the risk of return. The fire is out, the bleeding has stopped. Now what do you tell the patient about what happens next?
Now, a lot of these bleeds do stop on their own, but a pretty big chunk don't. Up to 1 in 3 patients will actually need some kind of intervention, like endoscopy or angiography, to get the bleeding to stop for good.
And the danger isn't over even then. Get this, about 15% of patients will have another bleed during the same hospital stay. It really highlights how important it is to get that initial therapy right and to keep a close eye on them.
And if we zoom out and look at the long term, that risk just keeps on climbing. By 5 years out, more than 15% of these patients will have had another bleed. That's critical information you need to share when you're counseling them and planning their follow-up. Which brings us to our final question, the one that looks to the future. We know the risk of rebleeding is real. So as you're getting your patient's discharge papers ready, think back to those risk factors we talked about. What specific, concrete advice are you going to give them to lower those risks and hopefully keep them from coming back?